All right, welcome everyone to PTTV. This is episode 6. Today we have a very hot topic. We're talking about the future and direction of manual physical therapy. Today I am joined by some of the industry's top experts. If you could all go around and introduce yourselves for the people that are watching. We'll start with you, Joe.
Sure. My name's Joe Bruns. I'm a physical therapist from Pittsburgh, Pennsylvania. Alex graciously asked me back after discussing ITBN syndrome and potentially the clinical illusion of ITBN syndrome a couple weeks ago. I'm a manually trained physical therapist through the Maitland Australian seminars. I'm also currently in the fellowship program with Sports Medicine of Atlanta and discussed this topic with Alex several weeks ago. She thought it would be good, so here we are.
Terrific. John, would you introduce yourself?
Sure. My name is John Ware. I'm a PT. I run the faculty practice at the LSU Health Science Center, New Orleans. I completed my fellowship in orthopedic manual physical therapy from the Gulf Coast Manual Physical Therapy Institute back in '98, and then I completed my hours for fellowship in 2004. And I'm primarily a practicing clinician, but I do some teaching in the DPT program at LSU.
Terrific.
Fire away, Tim.
My name's Tim Flynn. My practice is in Fort Collins, Colorado Physical Therapy Specialist. I'm in clinic 1 day a week. I have a faculty appointment at Rocky Mountain University of Health Professions in Utah, where I teach the professional level students as well as the doctoral PhD program students. And I'm also involved in Evidence in Motion, and we have both fellowship training, residency, and transition DPT training. My background is predominantly musculoskeletal orthopedic manual therapy. I've been a fellow for about 11 years. My background, though, was I trained more from an osteopathic background in the 80s and early 90s, and my research has kind of taken me different ways when some of the answers we got didn't really fall in line with what the models suggested.
Terrific. All right, so clearly we have some experts with us today, and with that said, we're going to jump right into it. So the landscape of manual physical therapy is changing a lot from its inception to today. So our first question is, what do you think the future and direction of manual physical therapy is, and underneath that, I guess, physical therapy in general? Start with you, Joe.
Sure. So from a research perspective, I think we've seen a shift in our understanding and the mechanisms behind manual physical therapy. There's this huge influx and increasing in our understanding of pain science over the past several years, which has taken us from practicing more of a musculoskeletal-based manual therapy to more of a neuromusculoskeletal physical therapy. I see the future of manual therapy incorporating more of this pain science understanding and more of this neuromusculoskeletal understanding. I know that it's definitely a hot topic right now, and there may be a little bit of a divide between some manual therapists out there, but we can't ignore the science. We can't ignore what we're understanding in relation to the brain's involvement with what we do to our patients. When we put our hands on our patients and palpate them and mobilize them or manipulate them, we used to always think that it has this profound effect on the joint, and we ignored the skin and the brain. And I think that the future of manual therapy is going to be involving the skin and the brain.
John, your thoughts?
Yeah, I would generally agree with Joe, but I'm a little more concerned about the future in the sense that I think if we do not embrace the current pain neuroscience, that I think there are going to be some dire consequences for our profession. I think the divide that Joe mentioned is probably wider than his rather charitable comment indicated. I think there's more of what I've heard referred to as a chasm, in fact, between the traditional practice of orthopedic manual physical therapy and the way I think it should be moving. And I'm concerned. And I think this is reflected in some of the documents that guide our profession. Our description of advanced specialty practice is very dated. It needs reform. The CAPT standards desperately need reform. They need to start, we need to, as a profession, both as individual clinicians and the institutions within our professional body, need to embrace the current neuroscience at our peril, and really more importantly, I think, at the peril of our patients. So I'm a little more, I guess, I'm a little older than Joe, so I've been around a little bit longer, and so I've just got a little more concerns.
I would say that the big concern I have is, I would echo what's been said previously, that where we get into problems is our understanding and our explanations. Our explanations fail us, and we know that it works, manual therapy works for a lot of conditions, and it's going to be a key driver in saving money and, frankly, saving lives in terms of some of the things that are happening in spine care. So on the one hand, we've never had more evidence supporting what we do in my career as a physical therapist. So we have this good body of evidence that has been developed that suggests in certain conditions manual therapy or manipulative care is very helpful. On the flip side, we have this body of knowledge, or I should say a historical perspective, that was focused around the description from the bones perspective. I mean, we come out of a bone setter tradition, and that's how manipulation began. And so we have the bone setter mindset, when in fact that is not consistent at all with the mechanisms that are going on for the vast majority of manual interventions. But people are hesitant to give up the models and accept the fact that it works and be embracing new models. And where I think I probably would agree in the last comment, that my fear is this, and I think it's best to put in an example of a therapist that is coming on in our practice, and we generally hire younger therapists that have been through an internship with us so they get our model and the language we talk to therapists. Had a very bright therapist that's begun working, and it was very clear that she started on an explanation to the patient about why she was doing things based on the mechanics of the sacroiliac joint. And whether or not in your mind you're using that model, which is fine in your mind, we should not use that with patient language. We should not be telling patients that what I'm doing is fixing something that's out of position, out of place, and the reason that your pain is there is by some bony explanation. And that is my fear, that we are at risk for doing what I often rave about, medicine causing fear in our patients in the explanations we give. And I've been a bit long-winded. I apologize.
No, not at all. You actually bring up an interesting point. So another topic that we were going to touch on was, should manual PTs utilize patient beliefs when choosing manual skills? So for instance, if a patient believes that they need to be cracked, should you crack them? So it sort of goes into, do you give them what you want? Do you explain it in a way, in layman's terms?
Okay, to discuss maybe a little bit further where Tim was going, I think that we need to set realistic expectation of what's going to happen once we perform a procedure with the patient. There is this this current belief by many individuals that are not in the medical profession as well as in the medical professions, that mechanics of a joint cause pain, and that movement of the joint will result in a decrease of pain. I think we need to move past that model, as Tim was saying, because I do think it promotes fear. It promotes fear of one's behavior. It definitely shifts, the way the brain perceives pain and allows patients to catastrophize upon their painful condition and move differently because of that. Getting more to your question, I think that the patient expectation definitely has an impact on results. I wouldn't say that I would expect manipulation to be more effective than mobilization. I recently participated in a randomized controlled trial with Chad Cook, who investigated and compared mobilization versus lumbar manipulation when individuals had this comparable sign. And what we found is that one wasn't more effective than the other, but patient expectation did matter. And clinician expectation also matters. So if I go into the patient room and I think manipulation is going to work for that individual, I may be biased. I may approach the patient differently if I go in to perform a low-grade mobilization. So not only does patient expectation drive result, but clinician expectation as well, or clinician bias.
Yeah, I generally agree with what Joe's saying, and I would extend that to say to back out and look at the broader picture of just the epidemiology of say chronic low back pain, but really any persistent musculoskeletal pain problem. The common denominator, or at least a common denominator, I don't want to jump too far out there on a limb, but a very consistent common denominator is this issue of patient self-confidence, self-efficacy, internal locus of control. And that's huge. And how, as a manual therapist, I need to really be cognizant of the fact that a lot of these patients' beliefs and ideas are really, they're erroneous. They think things are going on that are just not accurate, and like their bones are out of alignment or out of place, or things need to be put back, or they're not strong enough, or they're too weak, or they don't sit up straight. All kinds of things that we've learned that just aren't true. And so we shouldn't be cracking backs just because the patient expects their back to be cracked. We, as a wise PT colleague of mine said, our patients shouldn't leave our clinic dumber than when they came in. I think we can do a better job. We really have to. If we want to start getting these people well, that Tim referenced in his opening comments, that are ending up going to have fusion surgeries and all this nightmare that's occurring on a daily basis with patients being maimed, literally, to the tune of about $60,000 to $80,000 a pop. We've just got to change our mindset and take a broader view of the patients who are utilizing the resources. And there's just, all three of us know there's a much better way than these patients ending up under the knife.
I think the challenge becomes, that three-legged prong of, patient values, current best evidence, and help me out here. Current best evidence, patient values, and
clinician experience.
Clinician experience. Oh yeah, I'm getting younger, and clearly I'm older. My experience. Oh yeah, that stuff matters. No, yeah. I think the challenge I find is that it's knowing, and I believe that experience, and that's what drives me nuts about the experience talk. The true expert understands the window of opportunity you have to create change in a patient. In other words, I wouldn't say carte blanche that if a patient came in and wanted me to crack their back, that I wouldn't do it. If that gives me a window of opportunity to show change, this person has gone somewhere else all the time, and I can do that and get some immediate results, and then say, however, if you want to help me buy a new car, you could sign up for me to do this every 2 days or maybe every 3 days, and I'm pretty game, but it's not good for your health, but it'll be really good for what I'm driving. And depending on the humor, where the patient's at, I might go on a story about connecting with that patient. So I wouldn't carte blanche not crack someone's back that that's what they believe needs. Obviously, it's appropriate and safe from a safety perspective. But I think that's really where expertise has been undervalued. We thought expertise was actually what we did with our hands. Expertise is understanding who you can connect with, who you can kind of drag along to better health and to make better decisions based on science. You know, based on this is what's going to be best for you. But they may not be there right yet. And that's really where our job as an expert is, to kind of bring them in to make better informed decisions. At the end of the day, we can choose to make bad decisions, and I firmly believe that, but we shouldn't be part of that bad decision. We should provide everything in our power to guide them to a more informed decision when it comes to their health.
Very good. Anyone have anything else to add to that? Okay. Moving on.
So far, we all agree, pretty much.
So far, you all agree. Good.
Exactly. Just to touch a little bit on his point, as moving into this doctoring profession, I mean, doctorus means to teach, and I think that that's very important, that we're educating our consumer and we're also educating them in a manner that's consistent with the most current literature. I think that as the practicing clinician, that's the most important thing we can do at this point. Admit that 5 years ago I thought your leg was longer than the other leg, but our perception of that test, or our perception of things have changed a little bit. Admitting that maybe we were wrong in the past, but this is what we're understanding from a pain science perspective, so that we don't keep driving those false beliefs.
And I would just also add, I as well would not rule, make a carte blanche rule not to perform manipulation on a patient, but I just think it's really important that we start helping to change the perception of what we're doing when we decide to do a manipulation, and make it clear that we're not really sure what the mechanism of action is here, but we want to definitely eliminate the things that we know are not happening, and those are the we don't want the patient, again, coming out of the clinic holding those same erroneous beliefs that they may have when they came in.
So we talked a little bit about the patient's beliefs, but do you think that the clinician's beliefs ever influence patients' outcomes, their bias and their beliefs?
I'll jump in there. Can I take that question slightly different? I think their beliefs. Well, I'll let Joe answer that. I'll let you answer that, Joe or John, and then I have a switch on that.
Sure. I definitely think the manner in which we approach the patient, it's going to give off a vibe. If I think, or if I'm confident that a manipulation is going to affect that individual versus not being quite as confident, my confidence going into that patient interaction is going to affect the outcome. Patients pick up on things inherently, and I think that that also drives outcomes. I know with research right now, that study that I just talked about, we looked at clinical equipoise. How biased am I going into this study thinking that manipulation is going to be more effective than mobilization? Because it has this potential variable in which it may affect the outcomes. So I definitely think that clinician beliefs and their buying into the system is going to affect a patient's outcome.
Yeah, I would agree, and I would also say that can cut both ways, in the sense that if you're very convinced, I mean, and you're charismatic, and you have your salesman's hat on, and you're very convinced of the biomechanical model, that you most certainly can convince the patient that you, and I have. I've been guilty of telling patients that I was able to restore their nominate position and counter-nutate their sacrum and all those things. I'm guilty as charged, but and I was a good salesman, and I think I was reasonably confident and charismatic enough to do pretty, get good outcomes, but not necessarily in the long run, from that broader perspective, help to advance the science and our profession, and really make a larger impact on this really big problem of persistent pain.
Well, where I was going to go is that I think that the bias of the clinician actually affects the decision making as well before even the bias gets to the patient. And a great example is at the IFOMT conference, did a presentation where we had a case, and three different people from three different countries who were on the panel, and we decided what we would do with that patient. And I thought it was pretty, obvious that the patient was acute low back pain, no leg pain, and in most people's mind, again, I'm biased probably to research I read, I thought, well, at least early on, manipulate them and provide thrust manipulation, because the value, the bigger bang for the buck in the published research for somebody that actually meets a subgroup that's noted to respond, it's kind of a no-brainer, at least to do manipulation. That wasn't the response. The response was three very different answers for a patient that had back pain less than 16 days, no leg pain, and was, no red flags, etc. So I think the bias of decision making is huge. And then you couple that with the bias of the patient, or excuse me, the therapist, how they feel about the procedure and their comfort. And then you throw some more thoughts on the patient. And so I guess part of me says I'm still shocked in 2012 that, again, our work and others that have replicated it suggest, at least for this small subgroup, which, by the way, not that many meet this subgroup, for those it's kind of a no-brainer, at least in the first couple of visits, to consider some thrust manipulation on those folks, unless, that doesn't fit the patient's values. But other than that, I still find that confusing that, we don't do that. And I'm interested to see what John and Joe feel about that. So let's just throw out a case where we have somebody with acute low back pain, 16 days or less, no buttock pain, a little bit into the butt, but no red flags, and low fear avoidance beliefs, etc.
Shoot, Joe.
Okay, so my perception of that prediction, for which I know that you worked on, Tim, so I want to give you credit for getting published in the Annals of Internal Medicine, and I mean, big article. But I think that simply identifies a responder to probably no matter what we do. I think that a bigger predictor is if this individual is going to have maybe a within or between session change. So if I touch that individual and that feels good, then they're probably going to be, that's probably more predictive of a responder of manual therapy than if they just fit this rule. I think that less than 16 days, very acute case, no major disc issue, it's only going, maybe to their knee, not past their knee. They haven't, developed fear avoidance yet. They don't feel disabled because of this, and they're probably a mobile individual. They have greater than 35 degrees of hip internal rotation. So I think that prediction rule, at least from my perspective, just tells me this person's probably going to get better no matter what I do with them. The biggest, the better predictor for me is if I put my hands on you and just touch you lightly, does that feel good? That's probably going to be more prognostic, at least in my clinical decision-making model.
Well, how do you reconcile that with Hancock's work, where they had people where they looked at a subgroup of people that met the rule, and when they got mobilization, they didn't do as well? I mean, they're doing stuff to them. And Cleveland's follow-up, where they compared mobilization with thrust manipulation, whether you put somebody on their side or on their back, and the mobilization didn't do as better.
Yeah.
That argument falls because if they meet the rule, and again, it's a small subgroup, but I'm surprised that we can't agree on even this small subgroup, because there's two studies that suggest that your point is wrong.
Well, and I would go back and I would talk about clinical equipoise. Was clinical equipoise used in that study? So if I'm going to be a participating, clinician in a study, am I biased going in thinking manipulation is going to be more effective? Am I invested in manipulation? Do I teach CU courses on manipulation? There's different variables that may impact how I interact with my participants that study.
But how does that explain Australia then? Because I would believe that the Australians, they were, they believed in mobilization. I believe Aussies are into mobilization. Would you agree?
Most definitely.
And so they were believing in this mobilization, but their belief in the mobilization didn't show the effect sizes that have been shown elsewhere in two other clinical trials. They are marginal effect sizes. And then when they looked at the responders, and they believed mobilization was going to work, their equipoise was there, you didn't see it.
Yeah.
Well, since Barrett Dorco's not here, I'm going to invoke him.
Good.
Barrett would say the method is not the trick. And he published a letter in, I believe it was in JOSPT, Joe, wasn't it?
Yes.
That letter with Jason. And where they discussed this, manual magic issue, and they discussed how, what's different about manipulation? It seems to be the ritual, the drama. I think an analogous study that was done was a placebo study done on the famous Mosley study on arthroscopic surgery of the knee. And when the subsequent documentary that was done on that, one of the researchers that worked with Dr. Mosley remarked, well, the whole ritual around doing a surgery had a very strong placebo effect. So not all placebos are created equal, and then you add in some of the equipoise issues that or factors that Joe mentioned, and I'm just wondering if it's not just the whole drama of the manipulative ritual that might not carry a lot of the effect.
Boy, I guess that's a big stretch to say mobilization is not as dramatic as manipulation. I mean, again, just putting somebody and gradually rotating and pushing on them, that's not that dramatically different than pushing on them like this and oscillating on them with grade 3 type mobilization procedures. I think in our mind it might be, but I'm not sure the patient is seeing that dramatic difference. Again, you're talking effect sizes, dramatic effect sizes. Again, the Hancock group did not see much effect sizes with mobilization. Not 30-degree drops in the oswestry. I mean, if that's the case, why aren't people replicating those types of drops? 30-point drop in an oswestry. Going from 44s to 12s or 14s.
I think there is some other neurophysiology going on. There's the Denick factor. I'm not saying it's all placebo, but I do think when you compare mobilization to manipulation, there's a big difference in the big difference is the speed at which it's done, and I think that adds quite a drama factor.
Yeah, I think, well, how can we resolve the issue? Because I do think this is one of those at the heart of some of the debates on manual therapy, as if, first of all, I don't know how we ever got this term mobilization. It's kind of interesting in and of itself. When you look at grades of mobilization, that clearly was one school, and frankly, I don't believe Jeff Maitland was that tied to grades of mobilization. It was one small little piece out of a large tome, but boy, we kind of jumped on it as being a big deal, and frankly, it got people away from doing manipulation. And if the drama is bigger in manipulation, awesome. If there's a bigger placebo for it, great. And I'm all with you, John. That argues for the fact of let's crank up our placebo effect. And let's not say, well, I don't want to give placebo to the patient because I'm not being true to my belief system.
That, to me, is not the issue. And again, this comes back to the fact that we're talking about a very small subgroup of people. We're not talking about the people who end up costing the healthcare system the vast majority of resources. I agree. Getting back to what Joe said, I agree. These are people that a lot of them are going to end up getting better anyway. And there's a cost-benefit analysis that we have to weigh against what we know now about the neuroscience and the importance of internal locus and self-efficacy. I mean, and weighing all these other factors, we just have to, I just think we have to kind of start shifting our paradigm a bit more towards looking at the big picture.
I do not disagree, John, but that would say, again, the data shows if you don't get those people better quick, they cost the system more. We have shown that in groups that should respond, if they do not get their treatment, they end up taking more drugs down the line. Their Oswestry scores are higher. Those people are likely to be using the system. You have a window. I agree. I think we all agree we have a window of time to make a big impact on patients. And if we don't lose that window, and nowhere in there says that you do not talk about control and immediately get into the prevention of recurrence. All those studies immediately went into exercise, intervention, and prevention of recurrence. Manipulation was a small component of the overall treatment plan, right? High quality examinations, manipulation, core stability and strengthening, and teaching the patient to stay active and doing the things that the evidence says. And somehow we've anchored on this small little thing about manipulation and mobilization. At least much of the debate, it's still going on, at least at AOMP last year, it's still a debate.
Well, Joe, your study cast that you did with Chad Cook, or not your study, but the study that you
yes.
I mean, it sheds some. There's some doubt to be shed on this idea that, and there's also been a cervical study that also shed doubt on the fact that manipulation is more effective than mobilization. So, that jury's still out anyway. And then when we take that, again, with all the current neuroscience suggesting internal locus, we need to move towards empowering patients, internal locus, self-efficacy. I just think we might be jumping the shark here. We're ignoring the brain. We're ignoring descending inhibitory control at our peril. And I think we need to take shift towards a more interactive stance with our patient and less of an operative stance where we're doing things to patients. I just really think we need to shift away and get out of the turf wars with the chiros and be what we really can be, which is real therapists and educators.
I have no disagreement whatsoever, John, and I'm not sure how that changes when you talk about a subgroup, a small subgroup. If we look at, and this is always where I think my fear is this, that are we doing the same thing with the pain sciences? And by the way, I don't see any acute low back pain. I have chronic failed backs, and I always joke about the research I do. I get to see those patients occasionally when I'm out and about in the bar and somebody hurts their back. I see chronic failed backs, and I see it from a neuro perspective, and that's the language we do. It's a subgroup. To suggest that we now shift everything only to the neuroscience when that is very emerging evidence that I am 100% on board. But that doesn't shift the fact that we need to change how we treat individual patients immediately. Because if we did nothing but just saw all back pain patients and got them in early, taught them to exercise, manipulated some that needed it, put others into other subgroups, we probably would dramatically decrease the numbers that go on to bad things. We're not medicalizing it, is my opinion. I think other people are medicalizing back pain, and I don't believe that, at least those on this call are not really medicalizing it. But I don't want to just throw the baby out with the bathwater and now just say the neuroscience is now going to solve it all. I don't believe that.
Tim, I think you make a great point there, in which we're not seeing these patients early enough. I think that one reason why we're seeing, low back pain develop into something that's a little bit more complicated is because we're not seen as a practitioner of choice yet for low back pain. We should be that first portal, the first thing that patients think of when they have low back pain. They should be seeking our care. So we're seeing these patients that are 2-3 months out. They have fear avoidance. They have catastrophizing. They probably have some type of kinesiophobic behaviors. I think that we should be, seen as that first access point. When you think low back pain, you need to seek our care, and we just, unfortunately, majority of us aren't seeing that right now.
I don't think we will. Are you going to go in if you have an ailment? What do you normally go in for? What is your purpose when you have an ailment?
Can you describe that a little bit further?
If you are having a horrific cough and you go in to see the provider, what are you hoping to get accomplished at the end of that?
To get a diagnosis.
So you're just seeking a diagnosis?
Well, just making sure it's nothing serious. I think that's.
I don't think our patients, that's a component. Most of the patients I see are seeking relief. They're coming in to feel better because they're trying to get in a different state. Many of them are fearful of things that are serious, and by educating them, we can depress their anxiety and things. But most people don't like to go to healthcare, at least in our neck of the woods. They only go if they need to feel better. So I believe that if we can't make change within session, whatever mechanism we do, that may be talk therapy, which I do a lot of. It may be manipulation. It may be dry needling. It may be all these things. But if someone leaves our clinic in the first visit and we haven't made a change, my likelihood of seeing them and really getting buy-in goes way down. And I think we can all agree that data says change within session is a cool thing. So I believe firmly that just talking with folks, breathing, you can make a change within session. It's harder to teach that, to do well, to be confident enough that you can do that, and we're not training our therapists in those skill sets to do that well. There are other things that give big bang for the buck that's temporary, but it does make a change within session. So I always say it's just your therapeutic window. I don't care what you do, but you better make that person feel better during that session, because then they get buy-in that you can give them a pathway forward. And only then, I believe, will we be the provider of first choice in musculoskeletal care. And just talking and just doing things, which I've heard this, where one school of thought says, I want to totally make the patient do all the movements because I want to empower them so they are in charge. It's a good theory, but if you don't make them better during that session, you have not improved their buy-in to that procedure. Having said that, there's a subgroup of folks, you just have them move, they will respond quite favorably, and they will get buy-in to the locus of control, and that they can actually be in control. And that's why I don't feel there's a huge, everybody has a piece of the answer, I believe, in some of these manual therapy groups, but they're so tied to their belief system that they can't see that it's just a part of the process. And again, I'm on board on the neuroscience, but it is not the end-all be-all. It is a part of the process that we need to integrate into the bigger whole.
No, great addition there, John. I'll just make this real quick so that you can add your points in. I think that to not make neuroscience, the whole picture. Why is the patient seeking our care? They're seeking our care for low back pain. I mean, pain 100% of the time is an output from the brain. We have to always understand that and look at that individual and understand how can we communicate with their nervous system. Everybody's brain and their neuromatrix, which is creating this perception of pain, is individualized. So to classify a subgroup of individuals and say, if they fit these prediction rules, then they have this neuromatrix. It just, from what we're understanding from fMRI studies, it just doesn't work that way. I think that we have to take into account a ton of variables within these individuals that may not have been investigated. They should be investigated down the road and with revalidation of the rule. But I think that there's some other variables that are likely contributory and completely individualized.
And I agree, but we have to function in the area with the evidence that we have, not with the evidence we'd like to have. And John, I'm interested in your thoughts.
Well, I'm guilty of a neurocentric approach. I don't really separate out when you say the neuroscience is being the be-all, end-all. I don't, I think it's all neuroscience. What's missing from some of the manipulation studies, the RCTs, is any kind of effort to incorporate some of Lorimer Moseley's work with patient education. I mean, he found, but just doing with patients with chronic nonspecific low back pain, and this was back in 2003, I think it was, Joe, that study on that he did detailed pain neurophysiology education, and they had improvement in their straight leg raise and increase in their forward bending. They had small effect sizes there, but they had significant reductions in their pain. That's a within session or between session change, and but that's not really being widely incorporated into physical therapists' standard interventions for even acute or chronic nonspecific low back pain. It's kind of it's still, and it's not like you mentioned. It's it's emerging neuroscience. This neuroscience has been around. Melzak's paper on the neuromatrix published in 2001, right, Joe? The dental education.
Yeah, I think he proposed it, but 2001 published.
Yeah, it was published. So it's, you can say emerging, but that's before you published your CPR study, isn't it, Tim?
But we're talking about two totally different subgroups, and that's why I'm struggling, because I'm agreeing entirely with you. I mean, our patient. I mean, go to our website. I mean, we have pain videos. They can't see us until they've gone through some pain neuroscience education. Because we see a lot of chronic failed backs. Having said that, when the engineer comes in, and the engineer, you would agree, you try to talk about neuromatrix with an engineer who's mechanical engineer and mechanically oriented, he is not there. And those are the ones that go on to multiple surgeries because they don't buy this thing. So I can talk about that all I want, but even Adrian and others say you're a good hit rate if you can get 60% of people to buy into the neuroscience education. That's been our experience. It's about 60%. But again, we're talking about the subacute chronic population, and that's why again I think we need to think about if they didn't get there, we have a different conversation. We know, I mean, I don't know about you guys, but I have had acute back pain and neck pain, and you know what? Quick do this, and boom, oh, that's better. It very well may have just been an experience in the brain, and that's cool. That's the mechanism that happened, but I felt better, and I'm not really thinking about it anymore. Patients don't think about neuroscience, the mechanisms, and I believe that we got to be careful that let's not extrapolate it to the acute back pain. Now, having said that, totally, let's not medicalize acute low back pain. Never use, that's why I started it, saying things are out of place and this and that. Talk about, the good news is this, you don't have anything seriously wrong, you're a little bit stove up, you're not moving real well, let's move you around a little bit, but more importantly, let's teach you not to have this happen again and not over-medicalize. I think we'd all agree on that. And that's neuroscience education, if you will, because we're not catastrophizing or amping up that patient. We're using the neuroscience to help in our education. But I don't think we can just say, what we've seen in these small effect sizes in the chronics, which, by the way, small effect sizes in the chronics are meaningful effect sizes. We should then say, well, if you can get a 30% drop in your oswestry, you can only get a 10% if I educate you, but I can give you 30 points if I do something else. That's not very appropriate in my mind. And that's really what I was trying to say, again, in the small subgroup.
And I don't want to get too far afield because, again, I can't remember the last time I saw somebody 16 days after onset of low back pain.
Precisely.
I can't even remember. So, but Joe's point is well taken, too. We need to be seeing more of those people, but I just want to make this statement. I think pain is pain. I think this distinction between chronic and acute is pretty hazy. I think the people who come in who are going to end up having chronic pain, it doesn't have, and the evidence pretty well shows this, is that it's not the severity of their injury or even the severity of their pain. It's other stuff up in their brain. It's stuff, their beliefs, whatever, all this stuff that is going to lead them down that road to chronicity and to being very expensive to the system and end up having surgeries and worthless, fungus infected epidural injections and all that kind of crap. So I'm of the belief that pain is pain, and we've made a lot of tried to make some artificial distinctions in that regard, and I don't think it's doing us any good. And I just think we need to try to incorporate the neuroscience with the entire population, acute, chronic, subacute, all of it. And maybe the reason why we're not so good at relaying this information to people like engineers is we're not good enough at it. We haven't practiced it enough. We need to come up with stories that are relevant to the mechanical people. I can make mechanical analogies with people. I can talk cars with those guys a little bit. We just have to get better at it, Tim. That's all. We just have to get better at it. We have to understand it better, and we have to start teaching it to our colleagues. And
I'm 100% on board with that, and I just want to make sure that we're not just thinking that will solve the problem. Because again, I was hurting like crazy after my 2-hour trail run with my colleague in my minimalist shoes, just because it's rocky in Colorado, and I was hurting, and but frankly, it went away after 3 days, but it was pain. It may have not, they were a little puffy, so maybe there was localized changes, etc. It was pain. Now, had it not gone away, it went away, so it's not even on my mind here on Wednesday, and that was Saturday. So I do think there's a difference. Persistent pain changes how we view, because it affects my ability to go run again. And if I'm not getting effects in my life, it goes away, I'm moving on. And so I do think there is rational reasons to separate things. We've seen the American Psychological Association change the idea of after death in the family, or any death, loss, depression is normal. But at what point does it become abnormal? Okay, to suggest we shouldn't feel sad is a little bit not understanding the human experience, right? And to suggest that we should not feel pain with doing something too much, but there is a point where, well, maybe it shouldn't be persisting. So I think that having some artificial timelines makes sense in musculoskeletal pain. Okay, it does, and we can all agree that there are different motivational factors. If I'm in a suck team in the NBA, I probably aren't going to, I might have more injuries at the end of the season, right? My incentives have changed. So, I don't know. So, bottom line is, I think we're agreeing that pain is complex and we need to be good at educating, but I don't think we should not put our hands on patients and use it as a window of opportunity to improve them.
I agree. I think the hands-on patient's definitely important, Tim. So great point. I think that, I don't know, I don't want to speak for John, but for myself, I think that, taking that point when we have our hands on the patient and just reconceptualize what's happening. Reconceptualize that this may not be doing a lot to your joints, but we're communicating with your brain. We're communicating with this complex mechanism that's creating this perception, and that sometimes pain's not a bad thing. It's a communicator. It's your brain's way of telling your tissue there may be something potentially wrong. Doesn't mean something majorly is wrong, but there may be a potential for further damage if we don't take care of this. So yeah, I definitely am an advocate for manual therapy and getting hands on the patient. And I think we should take that time to also educate and maybe reconceptualize what's happening.
And I think we need to be better in the papers describing the challenges, describing all that, what we just said, in the words that you're allowed to. Because the thought is that none of that is happening in these studies, where there's not communication going on with the patient and describing, you know, again, what is that language of this isn't a serious problem, right? So the language is saying, you know, the good news is, you know, you don't have any signs of anything serious going on, which with studies we've been all of that's been going on. So that's part of pain education, educating the patient that it's not catastrophizing the condition. And so I think part of it might be that we look at literature. The more I'm listening tonight, we read literature and we don't really get into we're not actually watching and observing what is happening. And it kind of goes back to your study, Joe, really, of saying, you know, there's a lot of stuff going on that we're not talking about, and we're spending a lot of time arguing about whether we wiggle it fast or slow.
Exactly. Alex?
Terrific. Well, we're getting close to the end of our time here, and we've obviously touched on a lot of topics in the context of the future of manual physical therapy. So I'm going to lead up to everyone their last words about the future of manual physical therapy, what you think is going to happen, what you want to see. Let us know. Joe, you can start.
Sure. I'm not going through fellowship right now for nothing. I think that there's an importance in getting our hands on our patients, whether that be, you know, getting our hands to allow us to have some personal time to communicate with that patient. I definitely think that it's a skill set that we should have as clinicians. I think that, you know, that dark road comes when we try to get a little bit too specific or think that things are happening that research may be telling us is not happening. From that point, we need to, you know, develop or utilize Occam's razor and follow the theory that makes the least amount of assumptions. I think the neuroscience, you know, perspective of manual therapy is kind of that model. So I think that the future of manual therapy is bright, and I know that Tim does some fantastic, you know, research to help support it and great advocacy work. So that's appreciated, and I definitely think there's a future to manual therapy. John?
Yeah, and I agree. Despite, you know, some of the comments I've made tonight, I mean, I put my hands on just about every patient that comes in the door. I just don't do much manipulation anymore. I don't manipulate necks at all anymore. I just think the cost benefit is just not worth it. Too bad we weren't able to talk about that a little bit, but maybe another time. Again, I'm concerned about the future. I think we're kind of we've gotten mixed up into the turf wars too much with some of the other manual therapy disciplines unnecessarily. I think if we're the ones who are really go by our motto of the science of healing and the art of caring, that we need to embrace the current science, and I just don't think it's really happening in a widespread way. And I know there's a lot of issues in reimbursement, the way physical therapists are reimbursed procedurally, and that drives a lot of it. There's the issue of physician ownership. We don't have autonomy, widespread autonomy of practice. That's a big issue that kind of affects us as manual therapists, certainly. But I'm just I think we need to start with our kind of getting our own house in order. I think we need to update a lot of our documents. The last DASP that the Academy come out with, I think, Tim, that was in '04, and it's looking through that. It still talks a lot about arthrokinematics, and there's just a lot of old verbiage in there that really needs to be cleaned up. And you know, the emerging neuroscience doesn't make much of a make much of a presence in that particular document. The CAPI standards are silly. The OCS exam has a lot of silliness on it, with you know, a lot of alignment tests and things that just are not supported in the literature. And we just need to do a better job about cleaning our house and decluttering. As Barrett would say, we're hoarders, and we need to quit hoarding.
Well, that's a great statement, and I would say we agree on 99%, and that ultimately that I believe the future is bright, because at the end of the day, you know, I look back to one of my mentors who was heavily invested in a biomechanical approach, Phil Greenman, a DO, yet that's not how he talked to the patients. I mean, all this stuff, this is just stuff for us to chat about and keep us up at night, but that language wasn't said to the patient. The language was, you know, let's get moving, you know, connected, like be with the patient, be what physicians and all health providers should be, walking with your patient. And we spend way too much time on discussing some of this wiggling and thrusting stuff. And people have not seen that that is just a component of what we do. So I guess I'm agreeing entirely that, you know, clearly we have to integrate neuroscience education in every patient. And how we do that, it depends, I believe, on that patient's values and how much they're willing to listen to us. And I'm a firm believer that buy-in is key, and that change within session gets you buy-in, and that is expertise, knowing that I can change through talk, through manip, through a needle, through whatever. And we can't identify those subgroups, but we are called, I believe, as educators, whether clinically, in the classroom, etc., we're called to not just say, oh, you'll figure it out in the clinic. That is such a cop-out. And to give some structure to students and residents and fellows to say, in general, dial up this type of approach with this patient, dial it down with this patient. And I think that's what we're called to do. And my final statement will be, let's keep the discussion going, but let's not have this too high level of discussion with the patient. I believe we should keep it simple. It should be based on science. That indeed this is an output, this pain is an output, there's ways we can dial it up and down. Totally agree with that. But let's keep it very simple in our explanations, because to suggest making things more complicated, and I think this goes back to what we just heard, clutters the issue and does not necessarily help who we're here to help, which is our patients.
Great. Terrific. Well, this is obviously a complex topic. We might have to do the future of manual PT part 2 sometime. You guys have sparked a pretty powerful conversation on Twitter, so we're definitely getting people thinking and learning already. You can follow that with hashtag PTTV6 if you want to keep talking about the future of manual PT, or go online to Therapydia.com to watch this episode again and share with your friends whenever you'd like. And more PTTV is on its way at Therapydia. And thank you so much for joining us, guys.
Thanks, fellas. Thanks, Alex.
Thanks, you guys. Thanks, Alex.
All right, thanks, Tim.
Thanks,
Night.
guys.
Take care. Have a great night.
All right.
You too.